No, the time is limited. Everybody has to leave at 1 o'clock or something. So please take your time to get your lunch. But meanwhile, we can just talk about these things. First of all, before I want to talk, I know this is a very general, broad audience, and I'm not sure how many of you are doing interventional fluoroscopy. I assume there are residents, there are medical students, and staff, everybody. So I wanted to start off with telling, like, let's say what's the general, what the first questions, things come in your mind when you say radiation. Just shout out any answer is fine. Like, are you guys worried about radiation? Not you. You know the answers. I'm talking about any questions. So let's say, this is March 11th, 7 years ago, Fukushima Daiichi nuclear power plant exploded. You already know. So let's say you get a free trip to go to Fukushima now. How many of you will take? Okay. How many of you saw Chernobyl HBO show? Okay. Half my lecture is done now because I can just quote the Chernobyl series to talk about. And you know, right now, after the HBO series, there is a spike in travel to Chernobyl. And in fact, that's called that nuclear tourism. And the radiation levels are pretty low right now. So you can go to Kyiv, take a flight, and then there's the tourist group, you can hook up with them, and they can take you into that nuclear power plant area because there are still people working there, and the nuclear power plant is slowly, they're dismantling. The radiation levels are reaching out to the background, so usually every tourist is given a Geiger counter to walk with it and see. So that's the situation. So you see, like, when the radiation comes, there's always extreme ends of information we have. Immediately comes into mind is like Hiroshima Nagasaki bomb, and Fukushima Daiichi nuclear power plant, and then Chernobyl, everything. But majority of the radiation we use in medical imaging is not of that level at all. Especially the one in imaging, for the fluoroscopy, we call it as a low energy radiation. Because I try to distinguish in hospital, we use two types of radiation. One in cancer center, when we are treating the patients, we use radiation, linear accelerator, cobalt source. They are all high energy radiation. They are usually in mega electron volt, MeV. Whereas the energy we use in imaging is all kilo electron volt, keV. So I call myself a low energy guy compared to my colleague who works in radiation oncology. He's a high energy guy. The second myth is among the medical students or anybody, I've heard sometime like, oh my God, I don't want to go into radiology or cardiology because I'll be exposed to radiation. That is also a wrong misconception, and because I've seen some people losing an opportunity to go into radiology or cardiology just being worried about radiation, without understanding that every time you eat a banana, you get radiation. Did you know that? Okay, it's called the banana equivalent dose. You know why? Because bananas are made up of potassium. You all know potassium. Potassium exists in all different levels in the earth crust. And one of them is K40, which is a radioactive. So every time you eat banana, there is some amount of potassium, K40, which is radioactive, you ingest. The best scenario is like, if you have a Geiger counter, and if you want to destroy a grocery guys in really sales, you take a Geiger counter in a busy Sunday morning and walk around the banana area, it's going to start chirping. Don't do that. But that's what we are all constantly exposed to, constant radiation. And how many of you know that we get a lot of background radiation? Probably all know. On an average in the US, we get about 3 millisievert of background radiation. How much that equal to a chest x-ray, let's say? That's equal to about 300 to 3,000 chest x-rays. We are constantly exposed to, from variety of sources, from background radiation, from cosmic radiation, from material we inject, like all the smoke detectors have some small amount of radioactivity there, because that's how it powered up. And even sometimes the gypsum boards sometimes have this very strange. What I meant to say is, like, humans have evolved over the years with this background radiation, and in fact, in some areas in the world are very high background radiation. Like, for example, some of you might be from part of India, Brazil, or Iran, where some part is the background radiation is almost 3 to 10 times more dose. Like, how many of you have been in Colorado? Colorado is also very high radiation because of the elevation, plus there is a lot of radium deposits. Because of that, but we have grown up in this, and it's very difficult. So, however, when we say about radiation in imaging, people get worried about. To such an extent, sometimes patients are cancelling their required CT scan or imaging. Having said all these things, I think I got now some ideas. The reason why we are all worried about is, let me see. This is the concept. Probably has seen this on slides many times. And the reason why we have this concept is radiation. We cannot smell, we cannot touch everything. And in addition, we all read comic characters. How many of you have seen comic movies? Like, Marvel comics. Incredible Hulk. How many have seen Incredible Hulk? Okay. You know where the Incredible Hulk real story goes back? He was a physicist working for US government. They're doing a testing in the Nevada desert. A child runs towards, one of his colleague child runs towards a bomb explosion. So he goes and covers the child, and he gets exploded, radiation, and immediately he get all this development. So for every one good character, there are thousands of bad characters also. So we have it in our psyche. When you say radiation, immediately we worry about all these things can happen. Probably you also seen Fantastic Four. All the Marvel comics are now in movies. So any of these sources have very authentic places, like there is a source of one character coming out from Stanford Linear Accelerator. Luckily, they don't have any character from Hopkins cyclotron facility, which we had from 1940s. But having said that, what we are interested is in, like, we want to make sure, the reason why we are all here is like because some regulation happened. The reason why regulation happened is like back in 2001, there was a major case. A patient got severely burnt, and the patient was on the front page of USA Today. And this is done by a bunch of cardiologists who are very experienced cardiologists. It's not their fault, they're experienced people. However, the procedure was so long, the patient had a severe burn, and they had to get a skin drafting. And the review of the whole study came out is the jury awarded millions of dollars because none of the cardiologists any training on fluoroscopy radiation safety. So that is not that they were not experienced, but they didn't have any formal training. So in the US right now, every state has different process. Instead of Maryland, they passed a regulation, kind of like just to make sure that everybody is aware of this one. They have every new guy who's doing a fluoroscopy procedure need to have some type of a training. And every once in 2 years, you need to have at least 1 hour of refresher courses. I think that's one of the reasons why the hospital organizes this and gladly invites me every year to come and give this talk. I'm trying to make it different slides every time, but some of the fundamental physics doesn't change. It's the same thing. So what I want to share with you is like, because of this, let me see. In generally, we want to make sure that, as in medical sciences, every new procedure we are doing it, we want to make sure the potential benefits far outweighs the potential risks. Because of the same thing, if you're using radiation for imaging purposes, for fluoroscopy purposes, we want to make sure all necessary steps to keep the risk as low as possible. And some of the risks are so statistical risk, there is not even evidence, but still there is some worry about it, so we want to make sure that they are pretty much as minimum as possible. Just to show, just take a look at, I'm not going to ask you a question because we don't have time. Like for example, radiation remains in X-ray room even after fluoroscopy or CT scans are completed. Anybody else? Medical students? No. Because it's like a switch. Once you take the switch off, it's gone. Okay. So what I want to touch on these 3 things. One is the principle of fluoroscopy system, radiation reduction strategies, and radiation protection. Some of the dose reduction strategies which we discuss here, whatever steps a physician takes to reduce dose to their patients, it has a double advantage. One is it not only reduces risk to the patient, but it's also going to give a protection for themselves also, and we're going to walk through that one. So generally, you all know 1895 Röntgen discovered X-rays. Within a year, X-rays were used all over the world. In fact, in 1896 itself, at Hopkins, I dig out an article about radiation burn. It happened here one of the dermatologists written this article documenting 12 cases of patients coming, not patients, subjects coming with a skin burn. And to more dwelling it found was it is not the patients who were getting radiation burn, it was the persons who were holding the X-ray plate behind the patient. In the beginning, the X-rays is to take the patient, the technologist has to hold the plate behind the patient for 40 minutes to get one X-ray. When you are holding constantly, their hands got all injury. So anyway, that's why the radiation protection is very important. So what is fluoroscopy? So fluoroscopy is a real-time X-ray imaging. It's like moment you put the foot on the pedal, there is some image coming on. It's like taking X-rays, multiple X-rays, but each one frame is very low dose. You take multiple of them, it integrates, it contains like a constant movie loop, and that's what fluoroscopy, and this is called a dynamic imaging. So this is heavily used in interventional procedures. On any cases in the hospital, it is used for line placement, any type of things, you bring in a fluoroscopy system. Especially the technology is now so robust, you can bring it to any corner of the hospital and use it very efficiently that you don't have to take the patient to the clinic itself, because that's the pretty much routine. So fluoroscopy doses per frame is much lesser, but you add up together, it adds up. This is a very fundamental drawing of what the principles of the fluoroscopy systems are. One is any fluoroscopy tube, any type of system has an X-ray tube and a collimator. That's like the area where the user can adjust the collimation, the field size, and there is a table and the patient, and there is a grid. Grid is basically a strip of lead septums to protect a lot of the scatter radiation, and then there is all these boxes which captures the image, X-ray signals, and converts into image and so forth. So these are the different type of fluoroscopy system. Probably you have seen many of them. This is one of the most workhorse of a fluoroscopy system in any hospital around the world. This is the X-ray tube is under the table, the image intensifier in the top. These are lead skirts to protect the user standing next to that, getting any scatter radiation. And they view the images on a computer screen or a TV camera. That's pretty much the workhorse of any fluoroscopy department in the world. Now you move on to this interventional fluoroscopy, like cardiology or in interventional area in radiology. You have these C-arms. They are not protected by the table because the table allows you to rotate any directions you want. But this is a biplane system. It has two different systems. You can simultaneously image a patient while you are doing positioning a stent or a catheter or a stent embolization, everything. Now this is a very versatile system, a mobile C-arm. This is again, it can be rolled into any location, and these days this is getting really robust that it is used routinely everywhere. Pain clinic uses it when they are doing some pinch nerving, or this urologist uses it, the surgery uses it. So pretty much if you are encountering a fluoroscopy, if you are not a radiologist or a cardiologist, you are exposed to this by a mobile C-arm. Then you also have what is called as, then this mobile C-arm is a well self-contained unit. It has a X-ray tube, image intensifier, and a camera. So it's all contained in one setup. So at Hopkins we have about like 50 of them running around all over the place. Then from past 10 years, the system slowly moved towards digital. Now the digital, instead of a big image intensifier boxes, we have what is called as a flat panel. It is a digital detector, and it gives a lot more versatility to move around the patient. At the same time, it has a features when it is optimally set, it gives a lot of low radiation for the same amount of same type of image quality. So the flat panel detectors are now pretty much become a common source everywhere. Then you also have these new types in the hospital. I don't know how many of you seen this mini C-arm. Anybody seen this mini C-arm? Any hand surgeons? Orthopedic surgeons? It's pretty much, it's like as the name goes, mini is really small. It is almost the plate, it's almost as plate as it is usually used by hand surgeon for pinning the hands, like in they're doing a surgeons on a forearm or something. They can place the whole patient's hand on the table and do the guidance. And it's a very low dose system. And this is a slowly coming in. It's called an O-arm. It's almost like a donut, but you can open up the donut. It's more like a fluoroscopy C-arm, but the patient, this can be used for rotational angiography and do a lot of this CT-like imaging across the board. Anyway, So one of the things, here is a list of procedures listed which has a good potential for injuries. I am not sure how many of you have heard about this procedure, are using this procedure, involved these procedures. The majority of them are like blue, the white was in radiology, the yellow was in cardiology procedures or vascular procedures. These procedures are heavy, long, lengthy procedure and can take hours together to do under the fluoroscopy guidance, and if the system is not properly set, there is a good potential for injuries to cause to the patient. That is the idea, and that is where this optimization feature comes into picture. Now this is kind of like a recommended that whoever does these procedures to make sure that the system is properly set. When I say skin burn or radiation, there are two types of effects we see normally in radiation. Any type of radiation, it does not matter whether it is cosmic radiation or nuclear bomb exposure or anything. Generally the biological effect of radiation are classified into two categories. One is called the stochastic effect, the other one is called the non-stochastic effect. So what is stochastic effect? Stochastic effect is like a probabilistic in nature. Every exposure will have certain chances of causing this. How many of you bought a lottery ticket, especially when the jackpot goes up? You won't end up buying one, you buy 10. Why? Each one has the same chances of getting the Powerball, but you buy 10 because you want to increase the chances. Same analogy goes for the stochastic effect. Every exposure will have certain chances of causing this effect, but if you have more of these things, the chances are more. The same thing applied. But the difficulty with these things is it's very difficult to quantify. Like a lottery ticket, we cannot say what chances of it you are going to win the jackpot. Same thing applies here. You have to really do not know exactly. If a patient comes back 10 years from now and the patient telling like I am having a cancer because I was radiated by you 10 years ago, I don't know the answer. Like I cannot say no, I cannot say yes. That is the difficulty with the stochastic effect. But this one is little bit more handleable. This is called the non-stochastic effect, also called as the deterministic effect. This is the one which are of interest in the lengthy fluoroscopic procedures. When you do it for a long time, these effects are caused due to the direct damage of the tissues, and that can manifest into some type of a tissue damage, and these are usually visualized within days to weeks to month. So if a patient comes back with a classic hair loss or a injury, you know that happened within a short period of time, and the best example is observed within days to week. For example, here is an example. This is a very extreme case. This patient, as you can see the direction here, this is a person underwent like a cardiovascular procedure. The shape of the injury tells you it is like a biplane system positioning in opposite way, and the obesity factor also plays because larger the patient size is, the exposure is more because you need to penetrate more, so the system automatically produce more radiation to produce the same image quality. So resulting in this type of injury can almost equal to like 15 gray. 15 gray is a very large dose. To put it in perspective, we always typically talk about milligray, 1 milligray, 2 milligray or 3 milligray. If somebody getting like 15,000 milligray or 15 gray, that's almost like a therapeutic dose, and that's an injury, it's a permanent injury. So just to give an example, so the skin burns are very rare but possible. Then what about the genetic effect? So the idea of the genetic effect, this slide is just for the medical students who are here. Like, as of now, we don't have any evidence for genetic effects at the radiation levels we use in imaging. I'm not telling all radiation does not have genetic effect. I'm talking about the radiation levels or radiation doses we use in imaging in interventional fluoroscopy or CT or in X-rays. They don't have any evidence for causing genetic effect. So the next question is sometimes like, what is the general radiation exposures? Like, every exposure will have certain chance of cancer. For statistically, we use a model called 5% per sievert. Females are slightly higher than male. The breast tissues are slightly more radiosensitive than the other sensitive organs. So because of that, the risk is slightly more. But again, these are very large quantities, and pediatric populations are slightly higher risk than the older population. So we cannot. How do we convey to the patient? We had a patient with like a guy came, like he had a question about his father getting a CT scan. He's already 80 years old, and the son is worried that will my father going to get cancer because of the CT scan? I could just simply say one statement: you won't live up to that time to get the cancer. But that's not my answer. So my point is, like, older they are, the stochastic risks takes time to occur, and each of these imaging is quite safe. See, the other question, I think this is another question probably many of you wonder, what is the effect on the unborn? So if I'm working in a fluoroscopy suite, I'm going to be doing a fellowship or rotation in radiology or fluoroscopy, and I'm in a childbearing age, should I be worried? Yes and no. Yes, because as long as you're wearing all the protection, then you don't have to worry. So what is the general sense we have? The general sense is like the pregnancy is considered a very sensitive part in the first trimester, 2 to 15 weeks. The same thing applies for the radiation exposure also. If the fetus is exposed to large quantity of radiation, there is a lot of these effects can occur. There are some animal studies which we have, which will mimic the human pregnancy, and it tells us here. So if this is a mouse model exposed to 200 rats of exposure, that's a very large quantity of radiation. If the mouse models were exposed to more than 200 rats of exposure during the first trimester, typically we see a lot of this spontaneous abortion or prenatal death occurring in these mouse models. So, and whereas once the pregnancy is matured, we see more of organ deformity and other things. But my question then comes to like, what should we worry about? Then there is also an effect called decreasing head size and mental retardation. Again, we have seen in some of the survivor population in Hiroshima and Nagasaki were exposed to very large quantity of radiation, and their kids were having some of the kids born had a smaller head size. It's almost mimicking a Zika virus infection type of thing. Anyway, so now having said that, is all radiation going to cause these type of effects on the unborn? Not necessarily. So generally what we have here is like, let me see. So typically if a patient get a radiation exposure, it happens sometimes, especially even though in the emergency room, when you bring in a patient, you want to save the patient, you do all the CT scan, and then if you find out she is pregnant, we can calculate the dose what it is. Unless the dose receives more than 0.1 sievert in the first 6 weeks of, we don't consider that as an issue at all. So how does one get about 0.1 sievert of dose? That the person should have got more than 10 CT of the abdomen and pelvic within the 6 weeks. How many times have you seen a pregnant patient getting 10 CTs in 6 weeks? At least in my 15 years, I have not seen any cases like that. So it's very seldom. So the rule of thumb is like, if the patient is pregnant, if she comes to the imaging to be done, if that is imaging is the benefit far outweighs, is very high, then they should do it. There are two rules of thumb I advise the physician. One is, if the imaging does not involve the primary area of the abdomen and pelvic, any amount of exposure would not have any impact on the fetus, because the minimal scatter comes to the fetus is so small. So if you have a head CT or a chest CT or a extremities, should not be worried at all. Without even second thinking, you can get it done. Or fluoroscopy also. But however, when you are doing a pregnant with the abdomen and pelvic region is involved, then we can take necessary steps to minimize the dose, and there are methods to do it. For example, if a patient comes in for a interventional procedure and the person is fully pregnant, one of the advices, like if you can pass the catheter from the femoral artery with a minimal amount of time of fluoroscopy time, that minimizes the exposure. So again, none of these will come to this one. The same thing applies for anybody working around the patients in a radiation environment. We're going to talk about scatter radiation, and if you're wearing all the radiation protection principle, it should not be worried. I've seen in my clinic sometime, some people, in spite of all this understanding education, they wear an apron, they're wearing a thyroid shield, fine. In addition, they also hurt themselves by wearing what is called, how many have you seen the WWF belt? The big belt? So this person was having a belt, a lead belt, putting across the belly in addition to the apron. And the person was really hurting themselves because there is no need to. On the other hand, if you're worried about radiation, we have these radiation badges to monitor ourselves to see what's the scatter radiation you're getting. So that's the thing. I might be digressing, but I'm trying to also covering some of the concept which is very generalized to everybody working around the environment. So what is fluoroscopy? In the typical fluoroscopy system, all these operating mode. Moment you put on the fettle, there is an image comes out. Then you can go into magnification, you can magnify the image. Then you can also go into high dose mode, which means that is higher dose to penetrate larger patient. So you do the high dose mode, and the high dose mode usually typically gives out an audible signal, telling like it gives a really disturbing audible signal indicating the user that you are using a high dose. Then in cath labs you also have cine cameras. You record the whole process to view it afterwards. That's also one of the modes. Then in the interventional area you have the digital subtraction and geography. It is taking like an X-ray, first X-ray, and every other frame is subtracted from the original one, basically subtracting the anatomy, and you are only seeing the vascular structure, and that's DSA. So all these are different modes, and if you go down the list, the radiation exposure to patients go higher as we go down the list. So that's the general trend. So what we have is like, let me see, I'm going to put this one together. There are a number of strategies one can take to reduce the risk to the patient. Generally, this is very important when you're doing a lengthy procedure. For a simple procedure, let's say barium enema studies or like a swallow studies, there is so minimal time, the risk is much lesser. But whereas in electrophysiology procedure, EP procedures, it takes a long time, these becomes very important. The first is minimize time of exposure. So generally there is a joke in the fluoroscopy suite, it's called the lead foot syndrome. Have you heard about lead foot syndrome? So the guy comes, the pedal is underneath, the professor comes here teaching the students, put the foot on the pedal, there's no disturbance, so he'll be talking and talking and talking, the exposure, the patient is continuously exposed. There is no need to, we call it as a lead foot syndrome. One time we wanted to modify the switch by putting a small pin, but they would not allow, FDA would not allow. But then the collimation becomes very important. Collimating to the field of view makes a lot of difference in minimizing the risk to the patient. Then we have what is called as distance between the X-ray tube. I'm going to show you all these in examples, but these are some of the steps we're talking about. There is also a principle called ALARA principle. Many of you have heard this, a buzzword. It's called as low as reasonably possible. Means the advice is use the radiation as low as reasonably possible, not jeopardizing the way you're doing, but not to waste the radiation when you're using it. That's the idea of the whole thing. Then we have all these, this is like a user, the technologist will know, radiographer will know, and these are the various buttons available to use the systems. Like for example, these buttons will basically tell how the system to magnify, magnification mode, then this is a collimation mode, all those things. I'm not going to go into the details of this one, but if you are doing a fluoroscopy, and even if you have a technologist doing the fluoroscopy, for a physician, I advise you to spend some time to learn the system, how it's operated, the bells and whistles, so you can actually use it to your advantage. Now, in fluoroscopy, we have a feature called automatic brightness control, which means basically the X-ray tube and the image receptor, that is the image intensifier, senses what's in the path of the beam, and depending on the thickness of the object, it will generate more radiation or less radiation to maintain the same image brightness. That's called automatic brightness control. Because of that, what happened is like this patient required less amount of radiation because the amount of radiation coming out of the patient was sufficient to cause the same image quality, whereas the patient size increases means automatically the system will automatically generate more. That's why sometime in fluoroscopy when you're doing, we try to make sure the extraneous body parts are not in the path of the beam. If you're doing a cardiac heart area, there is no need to put the patient's arm also on top of it, because then the system will tell you, oh, there is a thicker portion and it can generate more radiation. Now, the other part is collimation. Collimation is like bringing the blades to an area of interest. It has multiple advantage. It not only reduces dose to the patient, plus it's also going to improve the image quality, plus it's also going to protect ourselves because it's going to minimize the scatter radiation. For example, here, this is a typical question we get. We have a new system in the orthopedics. The guys are doing a pinning of the arm, and they're like, oh my God, this system is so bad. The image quality is so lousy. It's all those things. You go there and you see that because they have opened up the field so large. When you open the field so large, it is trying to average the signal around the large area. Because of that, the image quality becomes so poor. So you just collimate to the area immediately the object looks much more straight. So the collimation is pretty important in fluoroscopy. Now we also have magnification mode. Means when you're doing a procedure you can magnify anatomy. So what happens is, like, when you magnify, it will automatically constrict to the area. Because of that, the number of photons reaching the image receptor is less. Because of that, it will automatically push the system to generate more radiation. Therefore, if you go into magnification mode, the radiation dose increases to the patient. So another advice we tell is, like, minimize the amount of magnification you use while you are doing the procedure, only when it is necessary. This is what the plot showing about the scatter radiation. So before that, I have another slide afterwards I'll show you, but this is the effect of field size. If you block the field size, the collimate to the area of interest, it will automatically reduce the patient dose, plus also reduces the scatter radiation around the patient. Every black dot is a scatter radiation coming out of the patient. So the the best analogy I can give is, like, if the patient is on the table in the cath lab or the IR, imagine that as the body of the butterfly, and the wings of the butterfly is the scatter radiation. Make sense? The wings are more thicker closer to the body and thinner at the edges. Same principle applies here for scatter radiation. It's more, the scatter radiation is more closer to the patient is more higher, but if you go few steps away, is lesser. So if you imagine that, then if you are in the room, just to observe the room, you can position yourself to stand where you want to minimize your scatter radiation. So the same thing here, it's like a butterfly pattern. The wings are coming out, every scatter radiation is more higher here and goes down as you go further away from the source. And here, for example, if you collimate to the half much smaller, the scatter radiation gets even much more smaller. That's the idea. Now this is another example, like where to position the patient. Sometimes you say, like, oh, you want to position the patient as close as possible to the X-ray tube so that you can see the position, and you can get a lot more. So what we physicists do is, like, if we want to understand a particular phenomena, we try to keep everything constant and change only one parameter. That's what we have done. This is like the distance from the source to the receptor is all the same, and it's 100 centimeters on all the three. And this is an ideal case where the patient is brought as far away as possible from the X-ray tube and very close to the image receptor. And if you close the radiation dose to the skin surface is 1 unit dose, in this case is almost 4 times more, because the patient is very close to the X-ray tube. So it's kind of advisable to understand which side is X-ray tube, which side is image receptor, and trying to move the patient far away from the X-ray tube, closer to the image receptor, is an advantage. Not only it reduces the radiation dose to the patient, plus this block will block a lot of the scatter coming to your body, so that is also an advantage for us. The same thing. This is a good technique, bad technique. Basically telling, like, it's more closer to the X-ray tube, so there is a lot more scatter radiation, and there is a lot more increase to the patient dose. Any questions so far? I hope you're not sleeping. I can see. So now, having discussed that, what is the radiation protection? So the radiation protection, before I talk radiation protection, there are 3 sources of radiation exposure in any X-ray room, whether it's a CT, fluoroscopy, or any room. If you go inside, one is the primary radiation. So the primary radiation is the one which is, when you put the foot on the pedal, it starts from the X-ray tube, and the field size is not larger than the image receptor. You can be assured, and that's by regulation, it's by requirement, it won't change. So unless you're in the path of the primary beam, you won't get primary radiation. So if you're in an X-ray room, the source of exposure one gets is not from the primary radiation, it's from the scatter radiation or some leakage radiation. The leakage radiation is minuscule compared to the scatter radiation. So if you take precautionary step to protect yourself from scatter radiation, you're going to get protection from both of them. That's the idea. And on top of it, these rooms are designed such that the wall is designed in a way, they're usually lead lined wall, to protect anybody standing outside from any level of radiation exposure. That's by requirement. So that we work during the design construction of the room to specify the wall thickness, so that somebody outside should not get more than certain amount of level of radiation. So the 3 pillars of radiation protections are time, distance and shielding. What I meant is like minimize the time of exposure, that's the maximum protection patient gets and also we gets. And the shielding or the distance is very simple. I think this will explain. Further away you stand, the less chances you're getting mauled by the bear. And that's, I think, I saw this and like, okay, this explains the time distance shielding in one slide. So that's the same thing apply. If you don't have to stand close to the source, stand away, further away, that goes by distance you require. Shielding is you have to have somebody in the path. So this guy is better protected by the other guy because there's a chances. Anyway, that's a bad joke. So why is distance? Because this goes by the basic physics principle 1 over r square. Probably in high school you have written volume of a sphere, 4 pi r square. R square is in the denominator. So further away you stand from the sphere, less scatter you're going to get, and that's what it is. If you stand here, it go to 90 mr per hour. You double the distance, the radiation is about 22.5, not 45 mr per hour. So it's an advantage for moving away from the source. Further away you stand, less scatter one gets. And in interventional fluoroscopy or any of the CM, this is the typical scatter patterns around the patient. The blue is the primary radiation. Unless you are in the path of the beam, you're not going to get a primary radiation. But the scatter radiation is more heavier here because there is a lot of back scatter coming on the patient. And there is also leakage radiation. So there is more back scatter, much lesser here facing the X-ray tube. So the radiation what we get in the room, the staff gets, is due to scatter radiation. And this is directly proportional to patient dose. So if you decrease the patient dose, the scatter radiation staff dose is also decreased. That's the idea. So back to the same principle. Every black dot is a scatter radiation, and this is a half a meter block. If you go about a few meters, you're already having less and less scatter. And here's one diagram trying to show the impact of the patient dose on the scatter radiation. On an average size patient, I want to draw your number. I don't expect you to remember the units, but let's say it's 11 milligray per minute. This is the patient requires was 11 milligray per minute. The scatter radiation is about 1 milligray per hour. Usually the scatter radiation is measured in hours. So if the patient size increases slightly, the system automatically generates more radiation. Because of that, the patient dose now is 33 milligray per minute. That's 3 times more dose. And the scatter radiation correspondingly increases. If the patient is about very extremely obese, it's about 8 times more dose compared to the average size. And correspondingly, the scatter radiation also increases. So the rule of thumb is like scatter radiation increases significantly with the increase of the patient sizes. This is the same thing. Flat panel detector. If the patient is here, it's higher patient dose. If the patient is moved more closer to the flat panel, it's lower dose. If you're doing an RAO or LAO view, because of the thickness is much higher, the higher patient dose is compared to the AP projection. So these are the projection, so different angles. So the rule of thumb is like, whatever the patient gets, we're going to get a scatter radiation about 1,000th of that if you're at 1 meter away. This pretty much works. We have done the measurement to see that in an average size patient. So if the patient is getting 100 MR, you're going to get, or if you get 100 MR, 100 R of exposure, you're going to get 100 MR of exposure at 1 meter. So that's the rule of thumb. Because of that, it's required to wear lead aprons. Lead aprons comes in 0.25 to 0.5 millimeter thick, and that's sufficient to protect most of the scatter radiation. It's protect 90%, 20 times the scatter radiation. Whatever hits the apron, it blocks by 20 times, so you're hardly getting anything. So wearing a lead apron is very critical. In addition, some of the clinics also sell these lead caps. We have written editorials against it. People are not happy with us, but that's the reality. It's not providing any additional stuff. It's basically expensive. We wrote about 3 different items about this editorial. One was this lead cap. Again, usually there are a number of publications came out in some of the journals, and if you see any of these articles, none of them have any physicist in the authorship. So a lot of them are sponsored by the manufacturers, and they tell percentage decrease, but in reality, when you look at actually the value decrease is very minuscule, and the cost is humongous. Then there is a second type of shield called the lead apron, like a latex gloves, even that is also not used. So anyway, 0.5 millimeter of lead thickness is quite sufficient to block off 20 times more radiation. Because of that, there is no need to wear that WWF belt if you are pregnant and all those things. So nowadays they also come as a lightweight aprons. There is a lead alloy material, and they are as much as good as they if they are equivalent to this 0.5 millimeter lead equivalent, they are pretty good to use. I use all the time because we have done some measurements and seen they take the weight of our shoulder a lot when you are doing a lengthy procedures. Again, now the Joint Commission also requires documentation, so the technologist checks the aprons for every year to make sure there is not gapping hole. It so happened one time, the fox watches the hen house. It happened one time. There was a news that one set of manufacturer's apron was radiating itself, because they had picked up some materials somewhere else, and that materials had radioactive materials. Because of that, these aprons were also radiating. So it was a big hue and cry. They had to take up everything. Anyway, so the checking is a very critical of routine checking. So how the aprons are to be worn? Usually in the EP labs and cath lab, they wear it 2 pieces so that you can distribute the weight, or 1 piece is fine. But this leaded surgical gloves we are against it in the sense they hardly protect anything. It's almost like an emperor's gloves. They hardly protect, and they're expensive, about $80 a pair. Oh, this is the aprons wrap around 0.25 to 0.50 5 millimeter lead is quite sufficient, and most of the rooms should have these type of a ceiling mounted shields. Positioning the ceiling mounted shields will protect the uncovered portion of the body pretty much. In the US, you are required to wear the badges outside the apron, so that the idea is to monitor what the uncovered portion of the body is getting, and that's routinely monitored by the regulation that it does not exceed the limitation. And even then the limitations are set very conservative level, so one should not be totally worried about if they get any RAM. Typically the fellows and residents get the highest in the first 3 months of their training in the cardiovascular area or interventional area. So at that time, wearing all these aprons, everything is very critical. We also use a lot of these lead mobile barriers. At Hopkins we have almost every room has these things. This provides quite a nice shadow region. Like a medical student is here to observe a procedure, he or she doesn't have to stand very close to the patient, they can stand behind it. In addition to wearing the apron, of course, stand it. Anesthesiologist uses a lot because they stand behind it and watches the observe the patient, so they don't have to be constantly exposed to the radiation, scatter radiation. So these are the radiation protection methodology one can take to work safely around the environment. So what about the eye protection? If you're doing a lot of procedures, we advise to wear the eye protection, but not a very fancy lens or something, but one which is covered, which really makes you nerdish. That's the one you have to wear, not the very fancy one. So you want to get a real protection, because otherwise what happens is like the scatter can hit your skin and then enter the eyeballs. But again, this is for those who are doing a lot of procedures, but not everybody is not needed, but it's up to you guys. Oh, this is the one I was talking about, the lead gloves. We call it the emperor's gloves because when you wear these gloves, you tend to put more in the primary path, and your fingers are going to get a lot more scatter radiation, and there is a publication basically documenting the quantifying the value increase in your fingers. So it's about expensive, $80 a pair or something. It's not much. If you are worried about your hand exposure, you can ask your radiation safety office to get a ring badge. Wear it for a couple of months and see what is your ring badge exposure you are getting compared to what's allowed annually, and that will answer your question a lot of the time. So the monitoring is very nice. I think everybody uses this radiation badges required, and at the end of the month they have to return, so that these badges can be read to see what's the captured energy it has, and the captured energy is equivalent to amount of radiation exposure they got. So that's how they will tell you what's the numbers you have. Most of them is like 0 because you're hardly getting it. If the worker declares she is pregnant, the institution has an obligation to give 2 monitor badge. One to wear underneath the apron, one above the apron. So both of the badges have to be returned routinely, because the annual limit allowed for pregnant worker is 1/10 of that of regular worker. So there's an extra precaution is already laid in. The word of caution is don't switch the badges when you're wearing one underneath the apron 1 month and 3 days and next day wear it outside, then you'll be totally psyched with some values coming out. And then you can actually discuss with your medical physicist to see whether that's really dangerous or not, but just the general advice is to position it in the right position and get it routinely returned to review it so that it is not exceeding any limitation. That's another word of protection. So this is the limits we use. What does it mean? For a radiation workers, for a whole body, that's the badge weighting, he or she should not get more than 50 millisievert or 5 rem in a year. The state of Maryland does from January to December. Luckily, they don't go by calendar year sometimes, not from the academic year. They go from January to December. So if the badges exceeds closer to the years, usually the institution pull the guys out of the service. We hardly see that. Sometimes we used to do that because especially the first 3 months of the fellows in the cardiology or radiology, they get very high badge reading. Again, these badge reading are outside the apron. The actual body is only getting only about 10% of the scatter, so you have to be. Then for the pregnant workers, you can see this is 1/10 of the limit, and in any 1 month is 1/100th of the limit. That's how it's monitored. And this is the limit for the general public is about 1 millisievert, and this is what we use for designing the X-ray room, so that if a general public standing outside, let's say there is an office space, administrator sitting next to each other for 24 hours, we can calculate and tell what the wall thickness has to be. Then as you can see here, the eyes, skin and hands are given larger accommodation because they have less sensitive organs. Because of that, the limits allowed is much higher. That's why the hands, you can just wear a ring badge and compare to what's the annual limits is allowed. So pretty much you can answer the question to yourself. So in conclusion, what I want to say is, like, first of all, there is no limit on the patient dose. That's the idea. I'm glad that is the way, because it's our prerogative to use the radiation as much as necessary to do a procedure. It should not be hand tied by some regulatory numbers. Whereas the users is regulated by the numbers of scatter radiation, but patient there is no limit. As long as the study is clinically appropriate, a radiation dose should not be a factor in limiting a study. Plus, working in a radiation environment is pretty much same as any other space. So any medical students and anybody having worries about radiation, they should not buy into some of the myths. So that's all. Thank you. Any questions?